Hello, my name is Shivani Ahlawat. I'm an MSK radiologist at Johns Hopkins University. I will be talking in this essential series on how to read MRI about the medial and lateral menisci. These are my unrelated disclosures. So today we will look at normal MRI of the menisci, focusing what the normal morphology and variations in morphology are, and illustrate the spectrum of meniscal pathology as seen by MRI. So we'll start first by looking at this normal knee MRI of a young person. So menisci are comprised of fibrocartilage. So they are hypointense on all sequences. So here we look at first the medial meniscus, that's the posterior horn. That's the anterior horn, and it's hypointense on intermediate weighted or fat sensitive sequence, as well as fluid sensitive sequence. Here is the body, which is often, to me, better seen on coronal images. So here we can see that's the medial meniscus body right here. And it's hypointense on all sequences. So that's what normal menisci look like on MRI because they're comprised of fibrocartilage. The medial meniscus is larger than the lateral meniscus, and they are both made up of anterior root, horn, body, posterior root, and posterior horn. So this is the posterior root of the medial meniscus. That's the posterior horn. The body, as we looked at previously, anterior horn and anterior root. And this is a transverse ligament, which is a normal variant. And this is a ligament that is between the anterior horn of the medial and lateral menisci. You can see on the coronal images nicely, as well as the sagittal images nicely. So that's a normal structure. The other structure to keep an eye out on is a meniscofemoral ligament, which is located here. And you can see it going from the posterior horn of the lateral meniscus to the femur. And it can sometimes have two bands or one band. And in this person, there's a single band. And that's the meniscofemoral ligament of Humphrey. So H comes before W. So Humphrey is located in front of the PCL. That's my mnemonic for remembering these. Here's another example. Now, this is a 3D sequence. We'll be looking at the menisci again. And so we can see here, again, body of the medial and lateral menisci, posterior horn, root, anterior horn. We again see the transverse ligament here, which is often present. And it's seen both on coronal images as well as the sagittal. And what I want you to know in this person is that sometimes the lateral meniscus anterior root attachment can be a little bit fissured. So be cautious about calling isolated anterior root tears in the lateral meniscus. And the posterior root and posterior horn of the lateral menisci, when you're scrutinizing them, you can often see the posterior superior and inferior popliteal meniscal fascicles. And the landmark to see is the popliteal hiatus, which is the popliteal tendon right here. This is another person, and we'll be scrutinizing this person's lateral meniscus. So what I want you to notice here is, again, as I pointed out previously, you can see on the sagittal sequence, the posterior superior and inferior popliteal meniscal fascicles. And sometimes the posterior inferior fascicle can simulate a tear, as maybe you could possibly think of this as being a tear, but it doesn't definitely connect the inferior articular surface. And be careful if you're a little bit hedgy or unsure, or it doesn't connect on two contiguous slices, then our accuracy does decline. The other thing I want you to notice here is the anterior root attachment has this sort of split appearance, and there can be this horizontal split appearance of the lateral meniscus anterior root attachment, and that's also a normal variant. The other thing I want you to notice in this person is the medial meniscus has a normal triangular shape that becomes kind of small in the body. In contradistinction, this lateral meniscus never quite becomes small in the body. And if you measure it, it ends up measuring almost 2 centimeters. So that meets criteria for a discoid meniscus. In a mid-coronal section, if it measures more than 14 millimeters, that meets criteria for a discoid meniscus, and those people are prone to tears more often. Now that we've looked at some normal variants and normal MRI appearance of the meniscus, let's look at some pathology. So criteria for meniscal tear is abnormal signal that surfaces, that extends to the inferior or superior surface. So looking at this medial meniscus, we can see there's this abnormal signal that divides the meniscus into an upper and lower half seen on sagittal sequence. So that's the posterior horn. And we can see it surface right here on the coronal image as well. So this meets criteria for a horizontal tear of the medial meniscus, body, and posterior horn. It's a common type of tear that we see in clinical practice. And there's no uncertainty in our minds with regards to the abnormal signal surfacing. So here is another example of a normal lateral meniscus. It has hypointense signal on all sequences, triangular morphology, and we can see the anterior root, horn, body, posterior horn, and root attachment. Now, when looking at the medial meniscus, we see the anterior horn, body, and we see that the meniscus is sticking out beyond the edge of the tibia by 3 millimeters. So if there's extrusion, and that's a secondary sign supportive of meniscal tears. We also see subchondral bone marrow edema in the tibial plateau due to meniscosteochondral unit dysfunction, a secondary sign supporting presence of a medial meniscus tear. And some people call it the shiny corner of the knee. And then as we go posteriorly, we see frank fluid signal and a vertical line going through the posterior root attachment. So now looking at the same thing on sagittal sequences, I like to go from far medial to towards the notch. And so we see triangular morphology of the posterior horn. We can see the posterior horn, then we don't see a posterior horn. So that's a ghost sign, also a supporting feature of a meniscal tear. And we don't see a definite, nice, beautiful root attachment. So this would be a radial tear of the posterior root that's complete. And there's associated medial meniscal extrusion and subchondral bone marrow edema in the medial tibial plateau due to meniscosteochondral unit dysfunction. This is a slightly older patient with clinically suspected medial meniscal tear. And we see abnormal signal that extends to the inferior articular surface. So it's met criteria for tear on MRI. It is, for the most part, an incomplete, predominantly horizontal tear. But what I want you to note here is if we start from the anterior aspect of the body, it's pretty smooth. And then as we scroll posteriorly, you'll see a displaced fragment. So a very small flap. This would be a horizontal flap tear with displaced fragment in the meniscotibial recess. So this is one of the last examples that I'll be showing you. And this patient, as you can see already through this midline image, has an ACL tear. So let's start first with the lateral meniscus. We already see abnormal signal extending to the inferior articular surface. So this meets criteria for tear. There's abnormal morphology of the body. It doesn't, and posterior horn, it doesn't look like a triangle. And there seems to be a little too much meniscus protruding into the towards the midline. So maybe a big flat fragment. So now let's look at this tear on the sagittal, and we see that the anterior horn, the posterior horn is completely missing. We have two anterior horns. So this is a big bucket handle tear of the lateral meniscus. And we can identify that that's the anterior root, body, and then it goes posteriorly here. And this is most of the displaced fragment. And we can see the coup contre coup bone contusions within the femur and the tibia. Now, what about the medial meniscus? So here we are able to see frank fluid signal, capsular attachment. which in a deficient ACL or ACL tear is a special kind of a meniscal capsular separation. We call it a ramp lesion, and it's a clinically significant lesion. So look out for that, the meniscal capsular attachment. There should not be fluid back here. So what did we learn today? How to diagnose meniscal tears. The diagnostic criteria are abnormal signal that surfaces on one or both sides, or abnormal morphology. And for abnormal morphology, first you have to know variations in normal morphology and all these extra attachments and variations in attachment that I tried to show some examples of. The diagnostic criteria for discoid meniscus, the most useful I find is meniscus measuring more than 14 millimeters in a midline coronal image. And make sure that you can see abnormal signal on more than one slice, because our accuracy declines considerably if we just use one slice. There are some indirect signs that are supportive of meniscal tears. I tried to show all of them. And then in my report, I try and put in a tear pattern where the tear is located, what all different parts of it, whether it is peripheral or involving all the different zones, and whether there's a displaced fragment. And MRI is a very, very useful and accurate tool for the detection of medial and lateral meniscal tears. Thank you so much.